Murthy sir, Uttam Mete sir, and Surya sir. Thank you, Surya sir, for giving me the opportunity. And we have a jam-packed program, so that's why now I'll start with the session. So the way that this has been designed, we've already talked multiple times. We're going to have two short talks, and the first talk would be by Professor Samir Trivedi sir, and in the end we have a short talk by Sanjay Sinha sir, and then we've had case scenarios. We are going to discuss 6 case scenarios, which you all know. You have been in touch with each other, and we'd like to make this session as interactive as possible. There would be questions which are coming from the chat box. So either myself or Surya sir or Uttam Mete sir would be forwarding the questions. And with that, we'll go to the first part of the CNE.
Just a minute. We'll just we have an honorary secretary USA is there. We'll listen to his message.
Right, sir. Thank you so much, sir. Yes.
Before we start, I welcome you all once again for this webinar on recurrent UTI. We all know that this is a very nagging topic. Patient keeps coming to us and again. Lots and lots of material is available in the textbooks. But when it comes to practical point, we need to have proper guidelines. So that's why the convener for this program, Dr. Nachiket, has made this session very interesting. He has made case scenarios so that it will be very useful for us. So we have senior most experts in this discussing the cases. It has been designed in such a way that a case will be presented to the moderator and the faculty will discuss the case. Before we go on to the session, I request Honorary Secretary USI, Dr. Uttam Mete sir, to give his message. Dr. Keshav Murthy sir, President USI, is busy. He'll join us in the middle. Uttam Mete sir, over to you.
Thank you and good evening, Dr. Surya and Dr. Nachiket, the convener for this USI ISU webinar. I think all of you will agree. So this is a privilege for me as Secretary of the USI to welcome you all. And I think all of you will agree that it is sometimes easier to do a PCNL or a partial nephrectomy rather than managing a patient of recurrent UTI or something like that. It's not only problem for the patient, it's problem for the treating physicians also. Sometimes we really don't bother. And as a surgeon, we always try to look for some juicy cases and you operate and run away. So I think that way this is the best topic which has been chosen by our chairman of the ISU and Nachiket. At the helm of affairs, like a convener, he has curated a nice program, and of course the esteemed faculty, all of them are very good in this field, and I'm sure the deliberations, not only that, what I can see that it is a case-based discussion, that is another added point. So I'm sure this deliberation is going to help all of us, not only the residents, but the our day-to-day practice for all the urologists. With these short remarks, hand over to Dr. Surya, please.
Thank you, sir. Thank you for those kind words. Then now I request Dr. Nachiket to take over and start the session.
Thank you, sir. Sorry for the lapse. So we're coming to the first talk. It will be a 15-minute talk, and this will be given by Professor Samir Trivedi, sir. And he will be talking about the epidemiology, the demographics of recurrent UTI, the incidence and prevalence. I'd like to ask the USI personnel from the office to mute everyone. And at that time, after the talk, then they can be unmuted. Everyone will be unmuted. Thank you. Samir, sir.
Thank you, Nachi. I'll start sharing my screen. So, is it visible?
No, presently not, sir.
Now it's visible.
Yeah, it's visible. Yes.
Okay, great. Thank you.
Yes, sir.
So, good evening, everyone, respected seniors, and thank you, USI, ISU, Nachiket, Dr. Surya, for this opportunity. And this is going to be one of those slightly boring talks full of facts and figures because this is a topic which deals with epidemiology and demographics. Nachiket has been very generous to allot 15 minutes to me, but I will like to cut short on that and maybe have more time for more interesting things subsequently in the session regarding the case discussion. So I won't take 15 minutes. So firstly, we start with the burden of UTI, which is the kind of substrate for recurrent UTI. So if you look at the global figures, the latest published data was somewhere around 2021. and around 150 million UTIs happen annually, and the global incidence overall is nearly 4.5 billion. And I have rechecked this figure, and this is authentic. So 4.5 billion is a huge number in terms of global incidence. Majority is in the favor of females as compared to males, and by the time a female reaches 25, the incidence of UTI is about one in every third female. And so is the case for lifetime risk. Women are having a much higher lifetime risk as compared to males. We know the definition of recurrent UTI, either 2 episodes within 6 months or at least 3 within last 12 months. However, we should be careful about the facts and figures that I am going to show you, because there is a substantial variation in the quoted figures, because the target population is different in different studies. Some studies have used urine culture as a criteria. Some studies have used symptoms as criteria. The follow-up duration is different. Some studies are population-based. Some studies are uh, healthcare seeker patient based, and so on. So we have to read the context of the figures also, and not just be focused on the absolute numbers, which is important in this. So irrespective of the numbers, we all know that the burden of recurrent UTI is tremendous. The number of visits that a patient has to make to the hospital, the number of antibiotic prescriptions that are being written, leading to subsequently the menace of antibiotic
Yes.
resistance. And these, I'm sorry, is somebody saying something? So antibiotic resistance, which results because of these antibiotic prescriptions, these are tangible effects. And then there are intangible effects, the effects on quality of life, sexual health, the work productivity, and so on. The most damaging one being the problem of antimicrobial resistance, because these patients are having recurrent episodes of UTI. They are being prescribed antibiotics repeatedly, sometimes even without culture, and sometimes over prescription is there. One of the CDC reports of 2014 says that as many as 40% of patients who received antibiotics in the hospitals for UTI could have been avoided the prescription of antibiotics. So such is the scenario in US, and we can imagine very well what is happening in our country, where there are no restrictions or any checkpoints. So epidemiology can play an important role if we can identify certain high-risk groups, which can be targeted prophylactically, and thus somewhat reduce the burden of antibiotic misuse. Coming to the recurrent UTI numbers, overall, if you look in general population, any woman who has a UTI once, 20 to 30% of those will end up having a recurrence. In specific cohorts like young sexually active females, the figure is somewhere around 20 to 30% across different studies. In elderly postmenopausal females, this goes even further up, around 30 to 40%. And overall, if you want to take one number, every third or every fourth woman will have a recurrent UTI after having an initial episode. If we look at the temporal pattern, the dynamics, most of these recurrences occur within the first 3 to 6 months, around 80%. And 80% of these recurrent UTI episodes are on account of reinfection. And this slide is important for PGs. They should know the distinction between relapse and reinfection. So relapses are less, but they are clinically much more significant than reinfections, because relapse indicates that probably the original infection is not getting cured because of various factors which should be looked for and treated accordingly. Gender-wise, females are much more common, and any recurrent UTI in male should be raising a red flag. Your antenna should go up, and you should look for any underlying factor which is likely making it a complicated UTI, and this should be treated. A male having a recurrent UTI without any cause is extremely unusual. If we look at the age-wise distribution, overall, there are two peaks in females. One is the sexually active young females, 18 to 30, 35 years. And second is postmenopausal elderly females above the age of 60, 65 years. If you look at the figure which I have shown here, infancy is the only period when boys outscore girls, and only uncircumcised boys, where the incidence of recurrent UTI is maybe up to 20% as compared to 8% in girls. Otherwise, rest of every stage of life, females have got a higher recurrence, and especially in the elderly females, because of the reasons which are listed here, which contribute to these recurrent episodes. If we look at the worldwide pattern, there is a substantial geographic heterogeneity in the burden of UTI. The pockets shown in the map as dark red or maroon, areas in North America, South America, Europe, and Australia. These report higher incidence, and the lifetime risk is higher in these parts of the world. But we must appreciate there is a counterpart to this. There is another figure which I have not shown you, which shows the mortality resulting from UTI across the world. And although these regions have higher numbers, but the mortality rates are low. And although African and East Asian or Southeast Asian countries have got a lower incidence, but the mortality rates are higher, probably because of healthcare access and resources which are there. If we look at the projections, the trends over the last 30 years and the projections for the next 30 years, there has been a substantial dramatic increase in the incidence of UTI over the last 30 years by 66%. And female UTI cases have gone from 185 million to nearly 320 million in these last 30 years. And it is projected that within the next 20-25 years, by the year 2050, both prevalence and incidence is going to rise significantly. And that is the projection. Now, urine culture is probably the most authentic way of documenting a UTI. And if we want to look at true epidemiology of recurrent UTI, probably we should look at studies which have used culture-proven recurrent UTIs. And this is probably the largest study published late last year from UK. They used an Oxfordshire community data set where more than 2 lakh women were tested by urine cultures. Out of these, about 85,000, that is 42%, reported at least one positive culture. And out of these women, 18%, that is more than 15,000, had one recurrent UTI episode during the median follow 6 years. And these were all population-based studies. They were not patients who were going to the hospital to seek healthcare. So this is across general population. Most common age group was 70 to 89. And in general, women who had recurrent UTI were 17 years older than women who did not have recurrent UTI. So age is supposed to play a major role as far as recurrent UTI goes. If we look at the absolute risk of having a recurrent UTI episode, so after an index UTI within 6 months, around 30%, within 12 months, around 43-44%, 2 UTI episodes after the index episode, 6.3% within 6 months, about 17% within 12 months, and so on. And if you look at this Venn diagram, which is there on the right, if you look at all the women, about 50% of all the women will have one UTI in their lifetime, which is the blue circle. Out of that, if you look at the green circle, 20% of these 50% will have another UTI. And then the pink circle, 30% of these 20% will have another UTI, that is second episode. And the red circle, 80% of these 30% will have another UTI. So you can appreciate that as the number of episodes is increasing, the chances of getting another episode keep on rising exponentially. E. coli happens to be the most common agent, even in the earlier studies, as well as in the Oxfordshire data set. This was 65% in the UK study. Earlier reported figures were 80 to 90%. And what is interesting is that if the index infection is by E. coli, then the second or subsequent recurrent UTI episodes are also by E. coli in majority of cases, more than 80%. Other organisms like Proteus or Klebsiella, they become important either in presence of any complicating factors or in the more elderly population. And lastly, if you look at the risk factors which are likely to cause recurrent UTIs, which have got a strong epidemiological association, the strongly associated factors besides the young sexually active women and postmenopausal status includes diabetes, history of exposure to antibiotics in the past, any voiding dysfunction which produces an incomplete emptying, and then behavioral factors like reduced fluid intake or poor hygiene or patients holding on to their urination for a long time. More interesting is that many factors which we believe to be associated with UTI do not have very strong evidence to back them up, like obesity or sexually transmitted infections or wearing synthetic undergarments. So normally we advise our patients, but there is really no strong evidence to suggest that these can be associated with a higher risk of UTI, whether in premenopausal or in postmenopausal women. So finally, I would like to conclude with these key take-home points. Overall incidence of recurrent UTI after the first episode around 20 to 30%. Most of these episodes occur within 3 to 6 months, around 80%. Most of these are on account of reinfections and not relapse, again 80%. The annual recurrence risk in women who are affected is around 30 to 50%. Females predominate by nearly 4:1 ratio as compared to males. The most common age groups are two, the young age group 18 to 35 and then postmenopausal, that is over 65. E. coli continues to be the most common pathogen, and mostly when the recurrent UTI happens, it's again the E. coli which is the culprit. And there is a substantial rise in the incidence of UTI over the last 20-30 years, and the projections are that within next 20-30 years, we are going to see another significant rise in the numbers. So overall, you cannot take recurrent UTI as a kind of isolated event. It's more of a predictable epidemiological pattern, and it's a very significant public health concern. And if we can take insights from the epidemiological figures and find out certain target populations which are at increased risk of recurrent UTIs, then maybe preventive measures can reduce some of the antibiotic burden and the burden of treatment for these patients. Thank you.
Thank you, Sameer sir. The data itself just shows, what a challenge it is for all our patients and for urologists. You were inside your first slide, as you mentioned, the prevalence would be 4.4 billion. This is just, massive, just considering the scale of the problem that our patients have. Thank you so much for this wonderful introduction. And so if there are any questions later on, I think that we have it inside a chat box and we'll be putting it up on our e-learning platform. So I think that now we thank you for, sir, you're bang on time as always, and your presentation was very crisp. Now we'll start with the second part, which is the case presentations. And before that, I would like to tell everyone that in the case presentations, I was helped with Surya sir. So it's just not my doing. And Surya sir has also guided me about the common, case scenarios that we see as urologists, and which will help our friends as well as our residents to understand how to manage and the important facets of managing recurrent UTI. So the first case presentation, our moderators and our faculty are with them. I'd like to introduce Professor Shivam Priyadarshi sir. Thank you, sir, for joining. And his co-faculty would be Dr. Pavan Vasudeva. And Pavan, as we all know, is from Safdarjung. Thank you, Pavan, for joining. So our first case is a post-procedural challenge. And with this, I'd like to hand over the proceedings to Shivam sir. He'll be presenting his case and we'll be discussing his case and the relevance with Pavan. Shivam sir, thank you so much.
Thank you, Dr. Nachiket. Thanks to USI for giving us this opportunity. And I welcome my faculty here, Dr. Pavan, and rest of the faculty in the group. So let me share the presentation. So can you see my presentation?
Yes, sir.
Is it right? So, so we all know one of the most important problem which goes after TURP, which is one of the commonest surgery that we perform, is the persistence of symptoms. So this case belongs to that scenario. So this is a 70-year-old non-diabetic male who presents with persistent dysuria 3 months status post-TURP, despite maintaining a good urinary state. So Dr. Pavan, this is just a brief statement. We know along with dysuria, there might be some associated urinary frequency or urgency symptom, etc. But importantly, that his voiding is normal, but the dysuria continues even after 3 months. So how would you just think about this case?
So at the outset, I would want to know a little bit more about the preoperative and the intraoperative information. What was the prior history? What was the indication for TURP? Was he on a catheter prior to TURP? What was the prostate size? And whether any intraoperative complications happened? How long did the procedure last? And for how long was he on a catheter? Broadly, I mean, some more information.
So very important that we need to have a proper history. How was the procedure done? What was the duration? Symptoms? Was he in retention before that? Was he in chronic retention? Was there a history of hematuria, lithuria? Was there a history of catheterization for a prolonged period? And what was his serum PSA level, serum creatinine level, the pre-op investigations, the ultrasound findings, uroflowmetries, urodynamics, if it was done pre-operatively. And yes, definitely during the surgery, what were the findings? What was the bladder capacity like? What trabeculations, the size of the prostate? Whether during surgery you found there were pus pockets, there were prostatic calculi found or not? Was the resection complete or not? How was it done, whether bipolar or monopolar? What was the immediate post-operative period like? What was the catheterization period? Was the traction put and for how long? And what was the biopsy report? I think all these things are very important while we kind of evaluate a case of post-TURP dysuria, which has persisted for 3 months. So let's assume that, yes, he had a normal bladder capacity, everything went on normally, there was no major post-operative event, traction was not put for a long period, and the biopsy came as normal BPH, right? So what next?
Broadly, if the dysuria is persisting for a longer period, either the inflammatory phase is getting prolonged, which means the proliferative phase is not coming in, and then we have to look into factors which could lead to a prolonged inflammation. That could be one sector, or we could be missing something which could be a stone or even CIS. Persisting dysuria.
Yeah, go ahead, please.
Post-op would again.
May I ask a question?
I think, Dr. Nachi, should we allow questions in between, or can we do it afterwards?
We will take questions in the end, or you can put in the chat.
Okay.
We'll discuss later.
Okay, right.
Fine. So, Pawan, so what do you think could be the possible causes? Number one, you said that if everything is normal, usually there may be the healing phase post-TURP can be sometimes delayed, right? And usually you find a period of 5 to 7 days when the patient do have irritative and storage symptoms and dysuria, but if it may prolong some time, it will depend upon the type of surgery done, what was the prostate like, and was there any perforation or kind of a pus pockets and chronic infection, etc., that may delay the phase. So what else could be the possible causes?
So essentially, if prolonged mechanical trauma, or if the thermal injury coagulative necrosis was higher, and if the energy at trigone, if you do too much work at trigone, then also that leads to persistent dysuria. If the surgical channel is not smooth and you have the remodeling of the fossa doesn't happen in an adequate time, intraoperative complications you already mentioned, and persistent UTI also can be one of the reasons which will which will allow a low-grade inflammation to continue for a little longer period, besides the CIS and a bladder stone, which should be in your DD.
Right. So as we know, that 15 to 20% of patients may report persistent or recurrent voiding symptoms after TURP. The goal here is to differentiate what could be the cause, whether it is an anatomical cause or functional cause, or it's just a delayed healing phase. So these could be the possible causes. Though he is voiding normally, but still the patient may have some obstructive pathology like bladder neck contracture or urethral stricture that has to be ruled out. Residual adenomatous tissue, any functional like detrusor overactivity or underactivity or detrusor dysfunction, any chronic UTI, as you said, and sometimes prolonged postoperative pelvic pain, which can persist. So what do you think should be the diagnostic workup? Yes.
So initially, urine routine culture is important, and if pyuria's continuing culture is sterile, which is usually what happens, that the inflammation is aseptic. But in some cases, I tend to take a post massage sample also, considering that is normal and considering the cytology is normal. Then you run the standard tests of ultrasound, uroflowmetry, post-void residual urine, manage conservatively for a while, and if that does not lead to anything, then you would need to go in and see what is happening, as in a cystoscopy.
All right. So as you said, the history of physical examination and at least an urine routine and urine culture probably is mandatory in this patient. And depending upon the scenario, we may even do a uroflowmetry, imaging studies, and cystourethropy may come up later. And sometimes we might have to do a urodynamic study also to find out if there is a detrusor dysfunction. So, what do you think could be the management strategies? Suppose the urine culture was negative, there was no infection, and the uroflowmetry appears to be normal. Though it may be, if it is abnormal, definitely your treatment strategy would be different. So, what do you think should be the management strategy in this patient?
So in a culture negative patient, aseptic inflammation is the most common reason. So for initially, I'd like to treat them conservatively, bring in all the lifestyle changes that Dr. Samir mentioned. Sitz bath often helps. NSAIDs remains the primary therapy. You can add chimeral fort, you can add pyridium. If you think there is a neuropathic component, sometimes pregabalin also helps. I usually would do this much unless the dysuria is worsening before going in for a cystoscopy.
Right. So it will depend upon your investigations. So if culture positive, definitely antibiotics. If you think there is anatomical obstruction, then definitely you go ahead with your cystoscopy followed by the whatever the problem is. And if you think there is some kind of a storage symptoms, you add anticholinergics, etc., or you ask them to have pelvic floor rehabilitations. So all this, but majority of the patients, if we rule out all these, then they would have a multimodal kind of approach. As you said, they may require some kind of a physical therapy, sitz bath, some neuromodulation, or sometimes there is neuropathic pain, which may be amenable to pregabalin or something, those neuropathic medications. So this is one of the surveys which was done in by one of the group, where they try to find out how the consultants manage these patients. And the majority used to give NSAIDs, the non-steroidal anti-inflammatory agents, and then followed by anticholinergics, alpha blockers, pelvic floor physiotherapy, antibiotics, phytotherapy, beta-3 agonist, gabapentin, phenazopyridine, sitz bath, and some opioids. So this was the key take from EAU guidelines. And as the initial assessment should be to rule out urinary tract infection. And this all thing we have discussed. The key considerations are dysuria and pyuria are expected during the early healing phase, and it may persist up to 6 months. And the main cause post-URP dysuria are glandular residual tissue, urethral stenosis, obstruction, bladder neck contracture, or sometimes detrusor dysfunction. And sometimes it is said that the bipolar TURP probably produces less dysuria than monopolar TURP, which may be debatable. And the early post-op bladder irrigation helps in preventing dysuria. This was one of the study which discussed about the features of detrusor function disorder in patients with dysuria in the long period after TURP. And they found this is one of the common reasons for persistent dysuria in patients post-URP. So the take-home message is that dysuria at 3 months is often functional, but anatomical obstruction must be ruled out. And pre-op UDS is increasingly recommended nowadays for patients with high-risk factors, particularly who are above 70 with comorbidities, pre-existing storage symptoms to predict post-URP functional outcomes. So a multidisciplinary approach is necessary for persistent pelvic pain syndromes post-URP. Thank you, Dr. Pavan. So this was in brief. So now we can take questions if Dr. Surya or Dr. Nachiket permits.
Thanks, Dr. Shivam. There are a few questions from the audience. The audience are asking questions through the e-learning platform, so we can't see the questions in the chat box here. A question from Dr. Philip Raj is there a role of post-massage sample collection in patients with post-TURP with this kind of symptoms?
So sometimes if the patient was on a pre-op catheter and if you're expecting a biofilm formation from there, it led to a post post-op biofilm formation in the prostatic fossa, then sometimes these urine cultures are negative. So even though we understand that indiscriminate antibiotics shouldn't be given, and majority of these are aseptic, but still at one point I do make sure that we don't have a component of prostatitis. I mean, in fact,
Yeah. Okay. There's another question. Do these patients require a longer course of antibiotics if the histopathology shows bacterial prostatitis? With symptoms, without symptoms? What is your take?
so majority of the times it is aseptic, and that should be the focus of managing the inflammation appropriately, and then going in for an early cystoscopy, because sometimes this inflammation is not getting solved because there is something inside. There's an Easter, there's some necrosis, necrotic tissue which needs to be debrided, or the fossa is not smooth. So over dependence on antibiotics probably is no, because that is usually not the cause.
So if the patient doesn't have any symptoms, even if the biopsy shows bacterial prostatitis, we don't need to treat.
As long as there's no fever, I do not.
Okay. So there's a question from Dr. Ganesh Kamath. He says that dysuria is a generic term. It is important to define the exact term. Of course, that's true. We need to evaluate what is the cause of this symptom. Any other questions, Dr. Nachiket, before we move on to the next?
So I think that we've had a wonderful discussion, and even the questions, they were very good. And I think that thank you, Shivam sir, and thank you, Pavan, for the first case. And I think that things have been put into perspective. And thank you, sir, for the wonderful slides and the take-home message. This is exactly what we wanted. And thank you once again. So now we'll go
Thank
to.
you, Nachi.
Thank you, sir. So now we'll go to a second case, and it's a very interesting case. And it's a privilege and honor that we have our teacher of teachers, Professor N.P. Gupta, sir. And he will be, discussing the case with our moderator, Dr. Mukesh Arya, sir. Thank you, Mukesh Arya, sir, for coming. Sir, can you please unmute yourself? And they will be discussing the sterile pyuria and sterile dysuria complex. And I think that. So they will be discussing this, and they have their case, and I now hand over Arya sir. Sir, please, your live, and please can you introduce your case, Mukesh Arya sir. Mukesh Arya sir, your
Yes.
I can see you.
Yes, sir. Yes, sir.
Mukesh Arya sir, if you swipe your screen to the left, then we can see you individually. I think that you must be on a different mode. Can you swipe your screen to the left? We can see you.
Okay, I thank USI and Indian School of Urology for this opportunity, and we have NP Gupta sir. So let us start our. Yes. Oh. Yes, sir.
But if you're having trouble sharing your screen, then I mean you can verbatim, because all of us know what the case is. You can discuss the case verbatim if you're having issues with your screen.
Yeah, this 30-year female with no comorbidities, with no surgical history, presents with incidental finding of persistent white blood cells in urine without urine culture positive. So how should we proceed? NP Gupta sir.
Actually, this is a typical of sterile pyuria, and sterile pyuria is defined presence of WBCs in the urine in absence of standard urine culture tactics. So there are several causes of the sterile pyuria, and they can be just indicates the presence of inflammation in the urinary system. And for that, we have several causes like inadequately treated previous UTI, fastidious organisms, sexually transmitted diseases, or some renal issues. So it is very important when we start these cases, we have to have a detailed history has to be taken from this patient, whether she had previous episode of UTI or not, whether she has taken any antibiotics or not, whether there is any history of sexual contact or not, because these are the precipitating factors. Similarly, any past history of stone disease in the or any other disease in the kidney. So like that, we should take a detailed history to know the background of the case. And then how we should proceed, we should do a repeat urine examination again to confirm that she had a sterile pyuria or not. We should also check the pH of the urine, whether it is acidic or alkaline. Because if somebody has got a acid sterile pyuria, denotes something different from the common conditions. And we should also do a routine ultrasound examination to rule out that he or she did not have any other, like a stone disease or any other disease in the kidney or bladder or ureter, which can give rise to sterile pyuria. So this is the way we should start in these cases.
Sir, what are common non-infectious causes of sterile pyuria?
Now, this sterile pyuria is divided into infectious causes and non-infectious causes. So in non-infectious causes, again, patient may have some, they may have the contamination of the sample by the vaginal secretions. They may have some systemic conditions in the kidney, like lupus nephritis, Kawasaki syndrome. They may be taking certain drugs. So all this should be excluded by taking the history in detail to find out. There may be some foreign body which we don't know. So these are the common causes of the non-infectious sterile pyuria.
Sir, what is the significance of sterile acid pyuria?
Actually, acid sterile pyuria in 2 or 3 samples, if it is persistent, then certainly we suspect tuberculosis. That is one of the common diagnoses in the past. And we have seen several number of patients with acid sterile pyuria. And we should take a history in detail again, go back to find out is there any past history of tuberculosis in the patient. Pulmonary tuberculosis maybe 10 or 15 years back. And then we come back to the urinary system to investigate in detail. And according to our studies, intravenous pyelogram, or now we have got a CT urogram, because very early calicial changes you can see only on these 2 investigations. We should do urine examination for acid-fast bacilli, and we can also, if they are positive, then we have to request for the culture. And if required, then we further proceed. And symptoms of the patient is equally important, whether they have got frequency, small capacity bladder. So that give a suspicion that there may be tuberculosis.
Thank you, sir. In the context of a patient with classic symptoms of cystitis, but there are low counts, say 100 or 1000 CFU per ml. So how to deal with this situation?
Actually, this is like a, we have a significant pyuria or insignificant pyuria. So if somebody has a count of 10 is to power 2 or 10 is to power 3, we think that it is due to insignificant pyuria, not a insignificant pyuria. So in this particular situation, again, we have to take a prior history, whether she had any antibiotic, she might have taken inadequate antibiotics, or she may have some resistant bacteria. And we have to also further investigate that she may having some kind of either a mycoplasma, chlamydia, tracheomonas, mycoplasma, ureaplasma, viral, fungal infection. So we have to rule out all these possibilities, and then we should either ask her to drink plenty of fluids, and if she is not very symptomatic, we can then like to repeat that sample again once a month to see whether pyuria is increasing or decreasing.
When should clinicians suspect sexually transmitted infections in context of sterile pyuria?
Again, the same thing goes back to the history of the patient. It's very important. Sometimes they hide. They may not be like to tell you whether they have a sexual contact. So you have to achieve the confidence with the patient. You have to talk to them in privacy and to take out this history if possible. Again, according to that, we would like to treat these patients. Sometimes we just treat on the basis of the symptoms only, and so investigations may not be required.
Sir, which viral infection should be considered in the differential diagnosis of a patient with sterile pyuria?
See, viral infection, again, herpes can be there, and sexually contact history may be there. So these are the common thing, but I have also seen in my practice, some patients may have the viral infections. So we have to take the history, and accordingly we have to find out. Then we should treat the fungal infection, this viral infection also. At the
Thank you,
last,
sir.
if we have so much patient is persistent, have sterile pyuria, we are not able to find out the cause. The cystoscopy may be done actually, and we may find out some lesions in the bladder, and then we may take biopsies and all that. I have seen cases of eosinophilic cystitis and all that. So that is also in our armamentarium, but that should not be the first thing. That should come at the last thing.
I have reviewed the literature, so I will present just a summary. That the sterile pyuria is presence of pus cells with insignificant or negative growth. In such cases, in females, as per EU guidelines, 2 samples, and in males, 1 midstream sample should be taken. These are commensals, and we should not treat sterile pyuria, otherwise it will there will be subsequent symptomatic UTI. The incidence of prevalence of sterile pyuria in healthy population is 5 to 19%, and the high risk groups are diabetes, elderly ladies who are institutionalized, or spinal cord injury, which may be very as high as 89%. But still, in all these groups, there are no recommendations to treat sterile pyuria by antibiotics. So what are the treatment guidelines? That in orthopedic surgery, elderly, institutionalized females, renal transplant recipients, diabetics, even those having recurrent UTI, there are strong recommendations to not to treat UTI. Only in patients where you are planning a mucosa breaching urosurgery or pregnancy, there are recommendations that culture-specific antibiotics should be given. Diagnostic evaluation in young patients, sometimes pyuria is because of chronic prostatitis, so distal rectal examination is must. If it is urease producing organism, there may be association of stone disease, and to prevent contamination in all patients, midstream clean cast sample should be taken. Why cultures fail? Because there may be sometimes fastidious organisms like mycoplasma, ureaplasma, which will not grow in the standard culture media, or if it is a slow grower like Mycobacterium tuberculosis, which will require special media and weeks of time. So in such cases, we have PCR or NAT for suspected UTI like Chlamydia trachomatis or Neisseria gonorrhoeae, or a recent antibiotic may mask the infection and pyuria persists. Pyuria, there can be non-infectious causes like urolithiasis, MASH, stent, interstitial cystitis. The systemic conditions like SLE, sarcoidosis, Kawasaki, these cause inflammation in various parts of urinary system and cause leakage of WBCs in urine. Similarly, glomerulonephritis, polycystic kidney disease are also the causes of sterile pyuria. Some drugs like cyclophosphamide, NSAIDs, penicillins can cause sterile pyuria, and if it is not must, one can stop these drugs for some time and can repeat urine complete microscopy and culture. Recurrent UTI and transplant clinical trials have shown that there is a risk of symptomatic episode if you treat sterile pyuria. In transplant also, there are no recommendations. In neurogenic lower tract dysfunction also, there are no recommendations to treat actively without evidence of culture positivity. So management principles that you have to prevent resistance, otherwise there may be Clostridium difficile infection. Avoid empiric therapy treatment. If it is mandatory, it should be tailored to the sensitivity pattern. And if a patient has sterile pyuria, you need not to have urine complete or culture in follow-up to prove that the infection has stopped or completely treated. Thank you.
Thank you so much, Arya sir, and thank you so much, NP Gupta sir. This was even an eye opener for me. I mean, conditions like SLE, sarcoidosis, Kawasaki's disease causing sterile pyuria. I mean, we tend to learn so many things from seniors. Thank you so much. And I think that I'd just like to add that a very important thing that was brought about by NP Gupta sir and Mukesh Arya sir was that females tend to have a lot of infections which don't come on culture, like trichomonas, ureaplasma, and also chlamydia, and these are the common infections that they see from the vagina going. So that's why it's very important for us to give these females also maybe a course of doxycycline, which will cover all these variety of infections which can cause sterile pyuria. Thank you so much. This was definitely an eye opener. One comment by Surya sir, please, in a comment.
Yeah, Dr. Nachikesh, there are a few questions. I think there is, among the audience, there is some confusion. This is not asymptomatic bacteriuria. There's a question by Dr. Sanchit. This is sterile pyuria. Patient has got symptoms, but pus cells are there, all cultures are negative. That means it is non-culturable organisms or probably TB. So that was the question. Even Dr. Ganesh Kamath also said, is it necessary to investigate sterile pyuria? The patient is symptomatic, obviously we have to investigate. So this is not a case of asymptomatic bacteria. And there's a question from Dr. Chandramohan, maybe Dr. NP Gupta sir can take. Single most important lab test for diagnosing GUTB in the present scenario.
I think so. I'll go with a PCR analysis, for Mycobacterium tuberculosis. So that is the one which has come up newly now, and we can have an early diagnosis. Otherwise, standard is the urine for AFP.
Sir, another question to you. In patients with sterile pyuria,
if somebody has already taken anti-tubercular treatment in the past, then these cultures may all again come negative. So PCR will be a better choice nowadays.
Okay. Sir, again, a question from me. In patients with sterile pyuria, would you like to go for the newer test like NGS, next generation, next sequencing, genomic sequencing? Because you do all cultures, it will be negative. Patient has got symptoms.
I personally don't have any experience, neither I have done it. If anybody has experience, they can share it.
Because there's a lot of literature coming up saying that in patients with this kind of, when we have ruled out TB, PCR is negative, but sterile pyuria, patient has got symptoms, and we can identify some rare organisms by doing NGS test.
But I think so we have to wait. We should not jump in the first episode only to go and do all these kind of tests, They are all costly tests.
Yeah. Maybe Dr. Shimam, would you like to add something?
Yeah, so the dogma that urine is in a normal person is sterile, no more holds, because we know the urine is full of bacteria, viruses, fungi. So NGS has told us. So there comes the principle of urinary microbiome. So we know urine has its own microbiome. And if there is a dysbiotic urinary microbiome, there are a lot of problems can arise. So a problem of recurrent UTI is one of the issues, the interstitial cystitis. Even they have said the urinary malignancy can occur after urinary dysbiosis. I think NGS tells you about the dysbiotic urinary microbiome, And that can probably not now, but in future, it may help us to evaluate and manage such patients.
Thank you. Thank you, Dr. Sumit. Dr.
Thank you,
Nachiket,
sir.
move
Thank you,
next.
sir. I mean, all of us are learning so much. So this is the latest which has come. The Shivam sir has shed some light on it, and it'll be very exhilarating to see what we get upon this new approach in the next 5 years. So now we're coming to our third case, and it is my privilege to have as moderator Dr. Umesh Sharma from RML New Delhi. Umesh, thank you so much for joining, and Umesh is also my student. So it's basically, full circle for me, teacher, student, teacher. So Umesh is today my teacher, and with Umesh as faculty, we have Dr. Lalita ma'am from Hyderabad, and they will be discussing their case. Their index case is of recurrent post-menopausal UTI, which is a very important clinical scenario. So with this, I hand over the proceedings to Umesh. Umesh, please take over.
Thank you, sir. Thank you. And at the outset, I would like to thank USI and ISU for giving this opportunity. So most of the things about the incidence, prevalence, and what are the various causes for recurrent UTI have already been covered by the previous teachers. So this case scenario is basically a post-menopausal female of 68 years, and she has a history of recurrent UTI. Presented with 4 episodes of culture positive UTI in past year, and she was managed with the antibiotic, full courses of antibiotic. She has no any comorbidities, diabetes or hypertension or any other things, and she does not have any urological abnormalities on the prior imaging. So, ma'am, what do you think? What could be the possible reason for this female to have this recurrent UTI? Lalita, ma'am, yes, please. Hello?
Can you hear me?
Yeah,
Yes,
yes.
sir.
So we need to go more into the history.
Madam, you're not audible.
Not audible. Now, is it
Better.
okay? So we have to know more about her history, especially the voiding symptoms. We need to know whether she has any voiding labs, any history of sensation of incomplete voiding, any history of recent hospitalization or catheterization, which can actually induce the cause the first initial episode of infection. And also in these women, elderly women, we also need to go into her bowel habits, whether she is constipated. That's also very important. So I need to know whether she has any of these voiding symptoms or sense of incomplete emptying.
So definitely these all the detailed history of female should be there to deal whether she has what are the causes of recurrent UTI. So ma'am, do you think that this definition of recurrent UTI in post-menopausal women changes or it remains same what we have discussed?
The definition remains the same. So 2 symptomatic episodes in the last 6 months or more than 3 episodes in the last 1 year. The definition is same for all women with recurrent UTI.
Okay. So moving
but
forward.
This has to be culture proven.
Yes.
We don't just go by symptoms.
So it should be culture positive and more than 2 episodes in 6 months.
Yes.
Then what are the key pathophysiological factors contributing to these recurrent UTI in these women?
So the most important reason why the postmenopausal women are prone for recurrent UTI is estrogen deficiency. So how estrogen is protective in a woman is, so whenever there is estrogen deficiency, the glycogen content in the vaginal epithelium decreases. So there is decreased lactic acid formation. So the pH increases, thereby replacing the lactobacilli by uropathogenic organisms like E. coli. So whenever there is estrogen deficiency in the postmenopausal woman, so the pH increases. There are so many changes which take place in the vaginal epithelium. So the vaginal flora is completely, the imbalance occurs there. The lactobacilli are replaced by uropathogenic E. coli, which then ascend into the urinary tract.
So one of the most important factor in postmenopausal women is the estrogen deficiency, and what you have said that estrogen causes a decrease in the disbalance in the pH of the vaginal mucosa. Apart from the other causes of
Other factors could be we need to actually have a detailed examination of the local parts in these women. We need to rule out if there's any prolapse, especially cystoceles, which can affect the voiding function of this woman and result in high significant residual urines, which can then result in recurrent UTI.
So high residual urine is another pathophysiological factor.
So we need to look for any other local pathologies, like in postmenopausal women and also in prepubertal girls, labral adhesions is another common cause for recurrent UTI.
Okay.
So careful clinical examination is very important in these women.
Yes. So what is the importance of local examination, and ma'am, throw some light over this genitourinary syndrome of menopause?
Yeah. So the estrogen deficiency causes this syndrome, what is called as genitourinary syndrome of menopause, which is earlier known as vulvovaginal atrophy or senile vaginitis. So, but now we know that the symptoms will the patient will be affected both by vaginal symptoms as well as the urinary symptoms. The vaginal symptoms being dryness, dyspareunia, vaginal. Yeah, can you hear me?
Yeah, we can hear you. Yeah. Please continue.
Yeah. So the vaginal symptoms are dryness, dyspareunia, local irritation, vaginal discharge, foul-smelling discharge, and the urinary symptoms being recurrent urinary tract infections and frequency, urgency. So all these symptoms are labeled under the under the title of genitourinary syndrome of menopause. So one of the presentations in this syndrome is recurrent UTI. So another important thing here is when a patient comes to us, to a urologist or a gynecologist with a symptom of dysuria in this age group, we shouldn't suddenly come to the conclusion that she has UTI. All dysurias are not UTIs in these women. It could just be that vaginitis, which results in burning when she passes urine. When the acidic urine touches the sensitive vaginal mucosa, the patient can have the scalding type of pain, which should not be mistaken for dysuria and should not be treated unnecessarily by antibiotics unless we have positive cultures. So examination is again important in these women to rule out or to know where the burning is.
So, ma'am, you have already elaborated the GSM. So, in your clinical practice, if the patient is coming with a recurrent UTI, so how commonly you associate the GSM with recurrent UTI? I mean to say, ma'am, each and every patient has this GSM symptoms, or is it what should be the incidence? What should be the correlation?
Actually, after menopause, almost 50% of the women will develop this genitourinary syndrome of menopause, but not every woman with UTI will have GSM. Only on examination we will know. The patient will not know whether the burning is coming from the urinary tract or from the vagina.
Yes.
It's for the clinician to examine the patient, and we can easily localize her burning when we examine. So the elderly woman, when we examine, she would point out the area of burning is at the introitus, not in the urinary tract. So that's how we differentiate. But that said, even if a woman has this senile vaginitis or genitourinary syndrome of menopause, so she is more prone for recurrent UTI. Even if that particular minute she doesn't have UTI. So for a woman with recurrent UTI, we need to rule out. So both go hand in hand. But it is not always, dysuria is not always equivalent to UTI. That point I wanted to drive home.
So, what investigations you need to do or ask the patient before going for the prior imaging of the patient?
So in the history, it said the prior imaging is normal. As I said, we need to ask about the voiding history, whether she has a good stream, whether she feels incomplete emptying, and also whether she has the habit of, every woman with UTI, not just postmenopausal women, we need to ask whether they have the habit of postponing voiding. This is a very important factor which is an important risk factor for recurrent UTI. women in our country, as you all know, have a tendency, especially those who are college going for working, who work outside their homes, they have a tendency, or especially those on travel, they have a tendency to postpone the voiding because they don't want to use the public toilets. So this increases their risk for UTI because we don't want we all know that the bacteria continuously enter the female urinary tract from the vagina and from the rectum. So the woman has to periodically empty the bladder to prevent the infection. So we have to ask this history whether they have the habit of holding urine because they don't want to use the public toilet. So we have to educate or counsel the woman that this should be avoided.
Okay.
And even if the imaging is normal, we still, especially in this age group, I would like to do a uroflowmetry.
Yes,
Just to
definitely.
make sure that the voiding is normal and there is no significant residual urine.
So urine routine culture and culture is negative. So urodynamic, do you go for urodynamic studies? No,
No, unless there is significant residual urine, unless her flow is not normal.
because
Otherwise, it's not required.
most of these patients, they are elderly patients, so there is a component of detrusor over inactivity.
Only if we find some indication, either the ultrasound showing residual urine or a flow pattern is obstructive. Otherwise, we don't do any invasive investigation.
So ma'am, should we rely on the prior urine culture pattern? Because in our initial first talk given by Dr. Samir, sir said that 80% of the recurrent infections are by the previous organism. So do we require culture each and every time before proceeding?
Yeah, especially in these women, postmenopausal women, we need to know what antibiotic would be effective in that particular episode. So before we treat a recurrent UTI, for treating recurrent UTI, we need to do a culture every time the patient is symptomatic so that we don't treat them with unnecessary antibiotics and we treat them with appropriate antibiotics. So as I said, every symptom, every dysuria is not UTI in these women. So we have to prove it by culture and give appropriate antibiotics.
Okay. So any role of non-antibiotic preventive strategies, if you're moving towards preventive strategies now, one is the definitely if there is a culture positive, you have to go and give the antibiotics.
Yes.
And what should be the non-antibiotic preventive strategies?
So actually, in this age group, we have very good evidence, strong evidence to advocate topical estrogens, that is vaginal estrogen creams. We don't use rings or tablets in our this thing practice. Only vaginal estrogen creams have a strong recommendation according to even the latest EAU guidelines. So, and they're found to be very effective in preventing urinary tract infections in postmenopausal women, especially in elderly postmenopausal women. In this age group, in our index patients, 68 years, estrogen is definitely going to reduce the risk of recurrence.
And what about this cranberry, D-mannose, probiotic? Because a lot of OPD we see these products being.
Yeah, cranberry may have some evidence, but D-mannose, according to the latest guidelines, as a poor recommendation. Probiotics I actually gave in my practice because that will again reduce the risk of reduce the need for antibiotic treatment. Definitely has a role, especially in the postmenopausal women. As we discussed, the underlying pathophysiology is low estrogen will reduce the lactobacilli and they are replaced by uropathogenic E. coli. So if we give probiotics in the form of mostly they're lactobacilli only, different species. So definitely have a role.
So these are the particular some situations like in case of there is an infection, then when do you initiate antibiotic prophylaxis? Like you give continuous prophylaxis, or you, if the patient is having some coital problem, then post-coital antibiotic prophylaxis. What should be the agent? What should be the specific duration for these antibiotics?
Yeah, actually, as I said, estrogen definitely has a protective role in these women. Before we move on to the antibiotic prophylaxis, these days we have another agent, methenamine, can also be tried if estrogen is not effective. And then finally, if none of the non-antibiotic prophylaxis is effective, we move on to the antibiotic prophylaxis, like in any other age group. In this age group, I prefer a continuous low-dose antibiotic. I don't usually advocate for post-coital prophylaxis for this age group. And the agent of choice is nitrofurantoin for me, 100 milligrams once a day, almost for 6 months.
Okay. And any other antibiotic like trimethoprim,
Trimethoprim also can be given as a prophylaxis, but we need to look at the local resistance pattern. Almost 30 to 40% of the E. coli strains in the present day practice are resistant to cotrimoxazole. So we have to look at the local resistance pattern before we put them on long term.
Most commonly, nitrofurantoin is the drug of choice.
Yes. Unless in this age group there is a risk if the patient has compromised pulmonary function, we have to avoid nitrofurantoin.
Okay. So I have made some key points from the guidelines. So
yes, please. Yes.
So diagnosis requires the presence of acute symptoms. You'll note a dysuria frequency, urgency, or suprapubic combined with a positive urine culture in these patients. For recurrent cases, a pelvic examination is recommended to check for vaginal atrophy. Already we have discussed what are the symptoms of GSM. And first like antibiotic is nitrofurantoin, followed by trimethoprim, sulfamethoxazole, and a single dose of fosfomycin can also be given. Definition remains the same. And vaginal estrogen is recommended to restore the vaginal flora and pH. Formulations include cream, tablets, rings. Oral estrogen is not effective for UTI prevention. And daily low-dose antibiotic can be given for 6 to 12 months if non-antibiotic methods fail.
So I would just like to modify one point there. Examination is required not just for recurrent cases. Any woman, that age group, recurrent, even if first time the patient is coming with UTI, please examine the patient.
Yes, of course. And if UTIs are linked to sexual activity, definitely we know that antibiotics should be given. And non-antibiotic agents we discussed. So lifestyle modification has some role. Hydration, hygiene, and bowel health should also be taken care. Thank you, sir.
Thank you so much, Umesh. I think that in Surya sir will have to skip the questions. This is because we have shooting over time. So, or if there is any important question that you'd like to put up to the panelist, Surya sir.
Yeah, we'll take this question from Dr. Pawan. Ma'am, can you tell how to what is your advice for estrogen application? How the patient has to apply, for how long? And patients with estrogen malignancy, what is the red flag?
Yeah, the induction is once a day for almost 2 weeks, followed by twice a week we advise for at least for 3 months. And with estriol, which is a weak estrogen, that too with local estrogen, the risk of malignancy is negligible. But in my practice, just to be on the safer side, if a patient didn't have a mammogram in the last 5-6 years, I advise a mammogram. And also, if a patient still has the uterus, look at the endometrial thickness. If the endometrium is already thick, I've had a couple of patients who, after starting on local estrogen only, we stopped using oral estrogen for local genitourinary symptoms. So the patients would come with postmenopausal bleeding. So it is always better to have a baseline endometrial thickness. And even if there is endometrial hyperplasia, it's not malignancy. We only have to assure the patient, withdraw estrogen, and maybe do a biopsy if at all the patient develops bleeding.
Yeah. Thank you.
Otherwise, the risk is negligible.
Thank you, ma'am. Thank you, ma'am. Thank you, Umesh. It was an exhilarating discussion. And I think that the take home about was I learned that estrogens can also be given intramuscular. So maybe I'll incorporate that inside my practice. Thank you so much for the which is a very interesting case. And as urologists, we get cross referrals for our patients who are having neurogenic bladder. So it's a case inside a neurogenic bladder, and the moderator for the case is my dear friend, Dr. Harpreet Singh from Jamshedpur. Welcome, Harpreet. And we have a star faculty today, Dr. Sanjay Sinha sir from Hyderabad. Thank you, Sanjay sir, for joining us. And with this, I hand over the proceedings to Harpreet. Thank you, Harpreet.
Yeah. Good evening, everyone. Thanks, USI. ISU Chair Dr. Surya Prakash and my friend Nachiket for giving us this opportunity. I welcome Sanjay sir, my faculty, and all the faculties. So what we have planned, we will keep it a more of an interactive. So I request resident to ask more questions. We are saving some time so that it will become more interactive. So coming straight away to our case, 20-year-old female who have a meningomyelocele and neurogenic lower auditory tract dysfunction, recurrent UTI 6 episode. She has been treated with antibiotics and she has been on clean intermittent self-catheterization 6 hourly and no other surgeries. This is the brief which has been given by ISC to us. Sanjay sir, my first question to you is, what are the challenges in making a diagnosis in neurogenic lower auditory tract dysfunction or symptoms, whatever way you want to take it?
Hey, hi, Harpreet. Good evening, everybody. I hope you can hear me. Can you hear me clearly?
Yes, sir, yes.
Are you audible?
Okay, right.
Yeah.
So essentially, in the neurogenic population, the two cardinal symptoms that we have by which we make a preliminary decision that somebody may have infection, that is dysuria and fever, both might not be present in a patient with neurogenic dysfunction because sensations are lacking, and they often present with atypical features. So patients might have an infection which we are not able to pick up. So that's the first challenge, because patients may present, for instance, with just alterations in the characteristics of the urine. Patients may present with things like spasms of their skeletal muscles. Patients may have recurrent autonomic dysreflexia. So you can have a very varied or just generalized malaise in patients. So there is a difficulty in making a diagnosis because patients may have very atypical symptoms, and some of these are described in what is called the UTI data set in spinal cord injury patients by the International Spinal Cord Consortium, published in 2013, and that's a good list of checklists to look at. But there's a different challenge, and that is another challenge, and that is that there are many features of infections which get mimicked by patients in neurogenic dysfunction, and hence patients may not have an infection and may get labeled as an infection. So there's a problem both ways around. You have patients in whom it's difficult to make a diagnosis, and then you have situations where the patient doesn't have an infection, but there are certain features in the presentation that mimic the diagnosis. So patients may have urgency, discomfort in the bladder, and because patients with neurogenic dysfunction very often have pyuria and positive cultures, you can't really make a diagnosis or rule out the diagnosis by the urine test. So sometimes it really becomes difficult to make a diagnosis.
So what are the possible reasons of this sort of presentation? Because these patients many times are on catheter. So it's very difficult. They come with culture report. They've gone to many doctors and they visited, sir, my infection is not getting treated. So these are the concerns and reasons. How are you going to talk to them and convince them?
So I think the key in this patient is that she's 20 years old and she's had 6 episodes of infection in a year. So the first thing that I would be looking at is, has she been well managed over the years with no infection, then suddenly infections have started in the last 1 year? Or was she actually never on treatment? She just initiated therapy and this is happening, because obviously our approach might be a little different in these two situations. Now, anybody who's coming with repeated, let's say she has been recently started, was never on proper therapy. She started therapy this year and 6 episodes of infection. So I would be looking at her compliance with the CIC protocol. Is she really doing the CIC? Because if patients do CIC 2 times in a day with a neurogenic dysfunction, which is high risk, they're very likely to develop febrile UTI. The second is look at the CIC diary. There's data to suggest that if you have individual CIC volume records repeatedly of above 400 or 450 ml, that correlates with a higher risk of getting urinary tract infections. If she was well maintained from before and has suddenly started developing infections, then it's crucial to look for things like, is there a new stone formation? Is there for instance, is there a change in her bladder behavior? So some situations, for instance, I mean, a neurogenic dysfunction because of meningomyelocele is unlikely to evolve, but some neurogenic condition may evolve with time. And in those patients, they may be well controlled. And the fact that repeated infections are happening might actually be a sign that the underlying bladder dysfunction has worsened or changed. And this is a red flag, in fact, for reassessing everything. So such patients should have assessment to check, is there stone formation? They should have assessment. If there's nothing seen, then they may require reassessment of bladder function. And they may require reclassification of their risk profile. So if patients were in the low risk or intermediate risk, you might actually need to reclassify such patients if they're having infection again and again.
Adding to the what you have added about, sir, classification of this and how severe it is, you look also into the bowel function of this patient, sir. Do you think
Oh,
that
yes,
bowel
yes.
dysfunction will also add to their recurrent UTI, sir?
Right. So I think there's a reasonable link between constipation and recurrent infections, especially in children, for instance. It is, but whether it would really account for 6 episodes of febrile UTI in a year, I would be skeptical. But we are looking at each and every aspect of the patient's management. And one of the aspects of management would be to look for whether the patient's bowel is well managed or not. So going back and reassessing bladder and bowel function is crucial in patients who have recurrent infection like this. Another thing is this lady is on 4 times a day catheterization, 6 hourly CIC. Often that might not be enough, especially if her urine volumes are on the higher side. She's likely to be having average CIC volumes on the higher side, and that, as I said, can predispose to infections.
Just to at this point of time, sir, will you like to do some blood investigations or urine investigations in this
Oh, yeah.
patient?
So if there are two different aspects of this. One is how to manage the current infection, which he has come with, for instance, and the other is the long-term care. So what I spoke right now was more or less about the long-term care. But let's come back to the immediate management of this patient. So somebody who comes with a urinary tract infection, if the patient has a mild kind of a presentation, then I might allow her to continue her CIC. I would send a urine culture and at that same time start her on an antibiotic awaiting the culture report. But if the patients have presentations in which I have a suspicion that there's a systemic infection, either they look sick or they have systemic features like hypotension, etc., or high fever, those patients it's safer to put an indwelling catheter. I would send her CBP. I might send her a renal profile to just make sure that she's not having other issues, especially if there's any compromise to the upper tract. And I would do an ultrasound scan to check whether whether there are stones, etc., which might be predisposing to infection. So immediate placement of a catheter, starting a broad spectrum antibiotic after giving a culture sample, and then awaiting the culture report. It's important in these patients to do a culture, and we can discuss that subsequently. And once the infection has settled down, then we would go back to the CIC after a period of time. Now, how long to give the therapy? Typically, it would be 7 days of antibiotic, especially if there's anything significant, reasonable significant infection. But if patients are not getting easily controlled, then you need to extend that to 10 to 14 days based on some of the guidelines, like the Canadian guideline, for instance, suggests that you can give 10 to 14 days if patients have more complicated infection presentations.
Sir, generally, if you see this girl who has got 6 episodes of infection, their cultures are, there's you find the whole big line of resistance bacteria. So what is actually your choice of antibiotic when you see this sort of patients?
So
As you mentioned that there are a lot of atypical infection also in this patient.
Yeah, so I think we must recognize that patients who are on using catheters, when they do develop a urinary tract infection, this can often be with organisms other than E. coli. So, I mean, the E. coli still remains the commonest. It's about 50% in the neurogenic population, but that's way below the general population of patients in whom E. coli is a much higher proportion. So it's more likely that you get a non-E. coli infection. It's more likely that you get a polymicrobial infection. So it's important to send a culture before you start an antibiotic in these patients. My typical choice is to use a third generation cephalosporin intravenous. That's what I would use in these patients to start with, awaiting the culture report.
So this girl who has a 6 episode of a UTI, you will try to make a proper diagnosis, what sort of, whether it was asymptomatic or a symptomatic bacteria. If it's a symptomatic bacteria, if there's systematic infection, you will start on IV antibiotics, you will screen the upper tract, you will look for cultures, you look for CBC, see for the renal functions, and you started and she's doing well, but she's not responding. You're seeing that her symptoms are continuing, and she has some not settling down. So do you think there's a role of urodynamics in such sort of patients, or when do you like to do a urodynamics in such a patient, sir?
So there were two parts to your question. One is there a role, and the other was when. So as far as the role is concerned, yes, if patients have unexplained breakthrough infections, urodynamics to reassess bladder function or low unit tract function is an important investigative tool. So if you look at the AUA guideline 2021, this is regarded as one of the key indications for repeating a urodynamics in a patient who was otherwise well managed before. In terms of when, there are two as issues. One is if you do a urodynamics too early, you will have artifacts in terms of you'll get storage phase abnormalities which are triggered because of the infections. You can get phasic contractions, etc., early sensations, low capacity storage because of the infection. And the other is in doing a urodynamics too early, you can actually have a relapse of the infection because of the instrumentation itself. So I would typically wait for the infection part to settle down. I wouldn't do a urodynamics within the first 3-4 weeks after an infection episode has happened. If I have very deep concerns regarding lower tract function which has not been addressed, and if the patient is having really florid infection, I might leave the indwelling catheter for a slightly longer period of time. In the short run, it really doesn't matter, and then assess her. But I wouldn't do a urodynamics within days, for instance, of treating a febrile UTI in an individual.
In this sort of case, what are your red flags in this sort of case? What sort of things when you act very fast and you'll know I have to take it very seriously? What are your red flags for this sort of patients who present to you?
So I think important red flags are this patient's presentation is a red flag. So getting repeated febrile UTIs, you expect, let's say, 1 or 2 episodes of infection in a year on a patient like this. Usually it shouldn't be severe enough to land the patient in the ICU, etc., unless they've got other conditions. So red flags would be, so the moment you get repeated febrile UTIs like this is a red flag itself. So patients who have storage symptoms which are not settling down, patients who are getting infections despite appropriate management. We need to search for diabetes. It's known that diabetes gets missed in neurogenic patients more often than in the general population. We need to look for all the other reasons that might happen in any other individual patient. Just because the patient is neurogenic, it doesn't mean that you can't get those things in the neurogenic patient. In a male patient, you need to look for things like epididymitis, prostatitis. These may be some sources from which you get recurrent infections. So I think these are all red flags. And then when you do the basic assessment, you look for stones, hydronephrosis, renal dysfunction. All these constitute red flags in patients with neurogenic dysfunction.
So, sir, you have managed this patient. Now, this patient is all right. She has responded. Based on her avoiding diarrhea, say whatever because you put indwelling, you know what output she's generating every 3-4 hours. You have decided on the course of CIC also. She needs a CIC in this particular time. How are you going to do you need such patients need prophylaxis?
So prophylaxis in the neurogenic patient population is an absolute last resort. Most data suggest that when you put patients on prophylaxis and these patients are on intermittent catheterization, so we are talking of a patient like this, then patients tend to develop antimicrobial resistance to this bacteria. So I would suggest that it should be an absolute last resort. So I don't remember the last time I have used an antimicrobial long-term prophylaxis in a neurogenic patient. So if you're getting repeated infections in the neurogenic population, you've got to search for an underlying reason. And most often when you address the underlying reason, the infections disappear. Now, if they don't, and as I said, that's very unusual. But if they don't, what are the other options that you have short of antimicrobial prophylaxis? Because as I said, antimicrobial prophylaxis carries a significant consequence in these patients. So some of the other things you can do is use of bladder irrigation with drinking water. So there's a weak recommendation from the EAU guideline. Doing that can reduce recurrent infections. The other is use of intravesical instillation, let's say of gentamicin. So there's a reasonable body of evidence now that instillation of gentamicin into the bladder at the end of the day can reduce recurrent infections without promoting antimicrobial resistance in the same way as it otherwise would, without the toxicity of using these drugs. The doses are not very standardized. People have used as less as 15 milligrams at night to 80 milligrams. The protocols are not standardized, whether you should use it daily, alternate day, weekly, twice in a week, etc. But the fact that it works is well established. So you could use intravesical gentamicin, agents like that. The other is use of, if you really need to use an antibiotic, use of cyclic, what we call cyclic oral antibiotic therapy has been shown to reduce the odds of resistance. So using alternate weeks of two different standard agents can help. Whether you can use a drug like methenamine, we can discuss maybe at the end. I have a presentation on methenamine. I have left a lot of time there for questions, so perhaps we can leave it for that moment.
Generally, what do you, your agents, what frequent do you use trimethoprim or use nitrofurantoin? Methamine, as you told that you're keeping for the last, but what are the general things you use in your practice, sir?
So as I said, I don't use. So I almost never end up using antimicrobial prophylaxis in the neurogenic population. So it's usually a sign that there's a breach in the management somewhere. So if somebody is getting repeated infections, I would suggest don't use antimicrobial prophylaxis. Keep searching for a reason. You should find a reason. There's a problem.
One last question before I move to guidelines. Sir, what is the indication of surgery in your setup or for that neurogenic LUTs, urinary tract dysfunction?
So the surgery would typically be because of uncorrected storage abnormality. So it wouldn't directly be for recurrent infection, but it could be indirectly because if there's an uncorrectable storage abnormality that's not getting addressed by conservative care, that might lead to infection. And we've shown from our published data that even in patients who have chronic kidney disease with recurrent infection, if you take care of their storage function, infection rates drop dramatically. So it's not directly to treat the infection, it's to treat the underlying reason for the infections. And once you treat that with an augmentation, for instance, that can take care of the recurrent.
Anticholinergics, sir? Anticholinergics?
Oh, we have we talked of, when you talk of surgery, it obviously implies that you have exhausted all this. As I said, patients have to be refractory. So patients have to be refractory, and so the use of a procedure like augmentation would be a last resort after, for instance, botulinum as well. So if the patients can afford it, and if the patients have primarily neurogenic detrusor overactivity and not poor compliance as a primary problem, after a failure of antimuscarinic agents plus minus mirabegron, there's some controversy about the utility in controlling pressures versus symptoms with mirabegron. I would use botulinum toxin, and if patients are developing upper tract changes or botulinum is not working, then I would consider augmentation.
So thank you, Sanjay sir. I'll just sum up what you have told. So you have told that UTI is very common in neurogenic lower tract dysfunction and carries significant implications. And diagnosis can be challenging, as you mentioned. There can be atypical, there can be autonomic dysfunction, parent can be spasm. So it's not very straight onward what we see. There are atypical or resistant organisms more likely. And you have suggested that third generation cephalosporins in your practice you use. And UTI might indicate it's an unsatisfactory correction of lower tract dysfunctions. And you have discussed that we should keep a low threshold set for upper tract imaging. That means ultrasound done, rule out hydronephrosis of the tracts. And you have told that we should able to make a differentiate between the asymptomatic, where you just see a colonization. You should not keep on treating just colonization. You should treat only if the symptoms are there, and optimizing the lower tract dysfunction management with low pressure storage. The idea of urodynamics is you have to give a safe bladder so the upper tracts are preserved, and effective emptying, which means that you have to plan your CIC properly so that this is the best preventive measure. Correct, sir? I summed it up?
Absolutely. Before we wind up, there's one question in the chat box, if the moderators give me permission to answer. It's from Dr. Gautam Chaudhary, that if there's recurrent UTIs and neurogenic lower tract dysfunction, will you suggest SPC and discontinuation of CIC for a few months? The answer generally is no. We know that if you put an SPC, with the passage of time, the bladder tends to lose capacity. It's better not to put an SPC in the neurogenic patient, but with one exception or caveat, you can say. In male patients who have a severe urethritis, those kind of patients, I might temporarily switch them to an SPC until the urethritis settles down and the urethra has cooled off, and I've made sure that it's fine for resuming the CIC from below. I think that would be the only exception where I might consider doing an SPC. Otherwise, I wouldn't.
Right. Thank you so much, sir. And we've really had a great insight into this challenging problem, and who better to understand the nuances than Sanjay Sinha, sir. Thank you, Harpreet, my brother and friend. I really appreciate all the efforts that you took for getting the best out of Sanjay, sir. I mean, it's always a pleasure listening to his concepts. As I previously said, he's a superstar of this topic, and he is an authority. And thank you so much. So with this now, we'll go to the next case. The index case is another common scenario that we see, and that is UTI in non-obstructing kidney stones. For this case, we have a moderator again, my friend and younger brother, Gautam Chaudhary from Jodhpur, and with him the faculty would be again my friend and very close friend of mine, younger brother Rahul Gupta. Thank you so much, both of you, for joining. And with that, I hand over proceedings to Gautam. Thank you.
Okay. Good evening, sir, and thank you for the opportunity to the USI and the Indian Institute of Urology. So you already mentioned the case. So she is 45-year-old female, no comorbidities, but having the UTI episodes almost 7 in last 1.5 years. And urinalysis examination shows that persistent sterile pyuria. She has taken
I can't see your slides.
You can't see slides.
Okay. Why not?
Gautam, share your screen.
Yeah, I have shared, sir. Okay, I'm sharing again. Sharing desktop. Can you see now?
Yes.
Okay. So symptom after taking the antibiotic, symptomatic failure. Is now can you see?
अच्छा अनम्यूट नहीं हो रहा है. ओके. अच्छा.
Sorry.
No, nothing. Go ahead, Dr. Gaurav.
Okay, fine. So in CT scan, there is a non-obstructing renal calculus in left kidney in the lower pore. It is around.
Sorry, I'd
1
like
centimeter.
to interrupt. Can we ask the USI office to unmute Dr. Rahul Gupta? I think that they've muted him because he cannot unmute himself. Navneet Bhai, can you please unmute Dr. Rahul Gupta?
Latest renal culture is mixed growth, consisting of the E. coli and the Proteus. No other symptom of the kidney infection. So my first question to Dr. Rahul: how often do you see the mixed infection and why?
Hi everyone. Thank you, Nachiket. Thank you, ISU, for having me here. This is a very important topic, and invariably what we find is we are seeing this thing in and day out, stone and mixed infection. As you asked me, how often do I see? It is about 5% of the patients do have a mixed infection. It becomes very difficult, and why this happens is because the stone is like a foreign body, and like any other foreign body, it forms a biofilm on it. And whenever there is a biofilm on it, it will invariably have multiple organisms. So that is one of the reasons, and we should often look for, if the patient is not responding to conventional the drugs we are putting the patient on, we should think that there may be some other infection which we are missing, and we should talk to the microbiologist to get us know about that.
Okay, so as you mentioned that uncomplicated UTI, let's take the simple UTI. It's a very less incidence of the coexistence of the two organisms, but complicated UTI where stone is the one of the causes. The incidence is rise. It is around 15 to 20% in some series, and in the recurrent UTI with the stone disease, because of the, as you mentioned, the biofilm, and second is sometimes stone itself is an infectious system. Infectious nidus is there, and then overeat the stone form. So that can be the persistent source of the infection. So as already you mentioned, most important is the biofilm, and second is the urea is driving the alkalinization, and then that environment promote the stone formation, and then this bacteria may lie inside the stone itself. And apart from that, some existing pathology like anatomical problem or some further small micro stasis in the calyx because of the stone, even though it's not looks like an imaging non-obstructing, but they may create the microstasis in the calyxes. And after taking antibiotics, there is selective pressure of the emergence of secondary organism. That is sometimes, and nowadays it is more relevant to have the mixed urine culture. So I'm skipping this because we commonly see these are the organisms. So E. coli, Klebsiella, Pseudomonas are the most commonly we are seeing. Second question to sir: is the non-obstructing stone is the culprit for this scenario?
Again, like you said, what we consider non-obstructing may not be purely non-obstructing. One. Second is that again, biofilm formation, which you discussed very nicely. Third, there is a chicken and egg phenomenon. There's a very good article in current opinion of urology by our own group by Zishan Bia and Dr. Vineet Gaur is also there. They have done a very good meta-analysis. I think if everybody can go through that article, it is very enlightening. And they have mentioned this chicken and egg effect. What comes first, stone or infection? And sometimes, we say it is a stone which is causing infection, but it may be the other way around. It is the infection which is causing the stone. So if you have a struvite infection or you have a ureus splitting organisms causing infection, in that case, it's very difficult to say what is causing what. But whenever it is there, and we have to take care of that. Again, calcium oxalate and phosphate stones and uric acid stones, again, the organisms can, the organisms can come there, urea splitting again, and they cause multiple infections in that case. So again, biofilm and urea splitting organisms, we should always be wary of.
Right, you said rightly, sir. So yes, if the stone is there and patient is having recurrent stone formation and having no other anatomical or other phenomena which explain the complexity, then we should think of the stone. As you mentioned, the biofilm and the urea splitting organism. So primarily two stone, as you mentioned, the struvite stone and the carbonate apatite stone, which contain the calcium phosphate compound. They have the very high, stone with the infection, and we all know that urea producing organism create then and initiate the stone formation because of the favorable pH. And in calcium oxalate and other stone where the nidus may not be the infection, but biofilm may still form over these stone, and they may also play a role as a persistent focus for the recurrent urinary tract infection in these patients. So this is the scenario. So third question to you, sir: how to confirm the stone is the culprit? That you are pretty sure that this stone is the causing the recurrent UTI in this lady.
See, again, I'll just tell you that it is very difficult to confirm with surety that what is causing what. One. Second, some investigations like a CT scan. There is an article which shows that the CT scan with differential Hounsfield units, that is a soft core and a hard outside, or a hard outside and a soft core, can pick up and guide you along with the urine routine analysis or the culture that you are going to deal with. This is the stone which is the culprit and causing the infection. Third, there are ample number of evidence in which the voided sample and the stone cultures are very different. 36% of the patients may not have the same organism in the culture when you do the stone culture vis-a-vis when you've done a random urine cultures. So again, coming to the point, to be with very surety, it is not very possible. But whenever it is, these are the telltale signs. You take the history, you go through the urine routine, the culture, the recurrence of the episodes. It should point towards that there is something between the two.
Yes, sir. You rightly said. As you said that practically it is not possible to get that I am getting the urine culture at the same time I am getting the intraoperative stone culture, and then we see the same organism. But theoretically, yes, if you want to surely label as that the stone is the culprit for this scenario, then we should send the representative sample of both things, and we should follow the culture. Second is stone composition analysis is also important. And here is important point while reading, I come to know that infrared spectroscopy is better, especially in this scenario, because in the X-ray crystallography, you can miss the struvite stone or the amorphous stone where the crystals are not there. So better to go for the infrared spectroscopy as a stone analysis in these patients that can tell the exact composition of the stone. So that can again corroborate or the scenario. And then we see the culture that these organisms are growing. And as you mentioned, clinical history should be corroborating, and pre-op CT scan you already mentioned. So these are the scenario by which we can come to know, not surely yes, but we can have some clue that yes, something is playing role for the recurrent urinary tract infection, especially with the stone. So, your fourth question to you: treatment protocol for the stone associated mixed infection. How you would like to treat these patients, sir?
So I see again coming to the same thing, we all disease the stone in India very often. To give a treatment protocol as such is not, there is no ideal protocol, no protocol which is documented and literature wise you can follow. Yes, this will be something like a catheterized patient who needs a TURP. So we go with this thing that this is going to be infected stone. We look at the urine routine. If there's a difference between a urine routine of 3 to 4 pus cells versus 100 to 120 pus cells. That will give you the level of the infection the patient is suffering from. You can get a culture done, and you can, as an institution protocol, start the antibiotics at least for injectable antibiotics at least 48 hours if you feel that the stone is an infected stone and the patient had a history of an infection or something. And then you can at least 48 to 72 hours prior to dealing with such stones, you should start on a culture specific antibiotic if that is available, or a broad spectrum antibiotic as per your hospital protocol, because you would have some antibiogram in your hospitals, and that is a community based only. So you can start that 48 to 72 hours, and then you can go in and operate such patients. There is no harm in doing that. The most important component which I will tell you is that if you are suspecting a stone which is infected, it is always better to do a complete job, and a low intracranial pressures are mandatory. You choose a procedure which gives you both, because otherwise the patient can easily land up in urosepsis, which is not a position we want to be in.
Very nicely summarized, sir. But regarding infection and when to start the antibiotic, there is discrepancy in the literature, because as you said that hospital based guideline plays a very very important role, because hospitals like ours, we see the MDR commonly, so we have to start the antibiotic especially after having the culture. Maybe if it is MDR or the Pseudomonas Klebsiella, then change of the stent and start at least 3-4 days prior to this plant surgery. And versus earlier literature where the book has written that you start 2 weeks prior to the surgery or an antibiotic, probably it's not playing important role nowadays because of a lot of resistance, especially in India. And the post-procedural antibiotic also should be adequate. Otherwise, the nidus will be there and the reinfection or the persistent infection may be there. So this is how you well said that intrarenal pressure like mini-pug is better than RIRS in this patient.
Gautam, just two short points I'll just make. One is that if required, pre-place a PCN, there is no harm in that. And two, from medical legal point of view also, you should document everything, because you never know that the patient lands up in sepsis, and then things can go bad in the court also. So you should always document these things prior, that you have explained the patient everything about this. Thank you.
Non-obstructing calculus, we can put internal diversion instead of PCN.
We can do that also. No harm in that also. But short duration, very short duration.
Yes, sir. Yes, sir. Yes, sir. And that too, if it is Pseudomonas or Klebsiella, then we need to replace it 1 or 2 days prior to.
If it is Pseudomonas, I put a PCN in my unit. It's a straightforward protocol. Any Pseudomonas, PCN first, and then you operate whatever you want to do.
Okay, right, sir. So So Stone, already you mentioned that the surgical removal is important with the low intracranial pressure. I'm not going to other stones. Preventive measure, you want to have some words how to prevent?
Preventive measures, again, some things are in your hands, some not. I'll just concise. Hereditary, it's not under your control. Diabetics, it is not under your control. Yes, the dietary changes can be done. Very high protein diet, hydration. If the patient is recurrent stone formers, they have to be on a regular follow-up, because they should get an ultrasound done repeatedly so as to know what is happening. And urine routine, once in 3 months, they should get it done to see what is happening to the patients. And long-term prophylaxis, if the cultures come positive or they're having recurrent infection, you should treat it to completion, and it should not be, there should be no residual infection. You should differentiate between a residual and a recurrent infection. So if there has been an infection, document that the culture becomes negative, and it becomes there should be no residual infection.
Right, sir. So already you said that what common advice we give to the patients, so patients should not have a stone, and I'm not repeating. So infection specific prevention, previous speaker also discussed how to prevent the recurrent infection, low dose prophylactic antibiotic, and especially in young female, if you can prevent this post-coital prophylaxis, because majority of the infections are ascending, and then they can then associate the cystone may play a role, so that can be given. And and then other like urological structural prevention we already discussed. And one important point here I came across that urine culture surveillance is important. If you see the patient having the recurrent urinary tract infection, then after finishing the stone and now no abnormality, urinary abnormality, you can ask for the culture. Even the patient is asymptomatic, that can tell you that something is there or not. So should I summarize? Because already we are running late. So
Yes, I
biofilm,
think that, yes, please summarize.
biofilm and the structural hysteresis, post susceptibility, and prior antibiotic use, they are important in the recurrent and dual infection even with the stone. What to treat first? Most resistant and virulent organism, empirical antibiotic, broad spectrum, so top-down approach is what is advised. In the non-obstructive stone, biofilm and nidus both play an important role, and CT scan already discussed, and dual track antibiotics with the stone removal is the key, and prevention should be followed. So I could see one question from Nachiket sir himself. He's asking, sir, you are asking that lower tract symptoms along with the non-obstructing stone with the persistent infection UTI. So what to treat first? That's what your question is?
Yeah. So I guess maybe Rahul can take the question, and then, yeah, Rahul.
Yeah, sir. Now, in the recent few episodes, recent few cases, we have seen that the stones leading to a very small capacity bladder and low tract symptoms. Why this happens, I don't know, but I've observed this, one of these observations, and lower tract should be evaluated, but the nidus of infection anywhere should be treated first. So you have to be aggressively treating them. And what patients normally do is they take it antibiotics for some time, then they stop it, and then they feel better, and then they become symptomatic and come back. You have to ensure that they take it for a long time. And secondly, the coming back of methamine, though I don't have much experience in that, but we have just started using it. I think the acidification of the urine should help. How much that helps, what people may claim, but Abhi, we have just started about 3-6 months back only. So I think in 1 year down the line, we may have a data to our own data and our own experience, and then it will be better to share it again.
Right. Thank you so much. So I think that I'm so sorry, Sanjay sir, Nilesh could not come. He sent Shailendra, and Shailendra is also in a rush because he's been sending me, messages that, I have to leave. So if you allow, maybe it'll just be 10 minutes, Sanjay sir.
No, so I'll do the presentation from the car because I need to go to the airport, right? Okay.
But
No
I hope
problem.
that you're not driving then.
No, I won't. Obviously, I won't be driving.
Right. Thank you, sir. So
you might not be able to see me. Okay,
right.
Right. Okay.
So, right, sir. So now we have the next case, which is also very important. Today inside NP Gupta sir's discussion, we got to know that, sterile pyuria in transplant patients should not be treated, which was very interesting and intriguing for me. So we're just going to have the last case, which is UTI in a transplant patients and its challenges. And the moderator for the case is Shailendra Goyal. He's replacing Nilesh. So welcome, Shailendra, and the faculty. We have Dr. Raghavendra sir from Mysore. Thank you, sir. Thank you for patiently waiting, both of you. I'm so sorry. Sanjay Sinha sir will be hearing you from the car. Yes, please, Shailendra, go ahead.
Yeah. Good evening, all esteemed faculties, and thank you to ICU to give me an opportunity to moderate this case. And I want to invite Dr. Raghavendra sir to discuss this case. Good evening, sir. The case is 52-year-old male patient, post-diseased male donor renal transplant 14 months ago, on tacrolimus, mycophenolate mofetil, and steroids. Stable graft function, creatinine 1.3, but 3 culture proven UTIs in last 3 months. So, so my question to sir is, would you label this as recurrent UTI, and why?
No, if a patient develops more than 2 episodes of culture positivity in 6 months or 3 episodes in 1 year, then you definitely label them as recurrent UTIs. As already in the evening, people have discussed, it's the same thing in the females. So this is definitely a case of recurrent UTI, as you already have 3 cases in the last 6 months.
Yes. And is this concerning in the stable graft function?
Yes, because these recurrent UTIs, they contribute to, they affect the graft function, contribute to increased morbidity, And in the end, going on, they may be associated with graft loss as well as mortality. So it is definitely a point of concern that the patient is developing so much urinary infections.
Okay. So, sir, you are going to treat this asymptomatic bacteria. Are you going to treat this?
The patient has culture positive bacteria, I will treat him. Asymptomatic bacteria, no.
So, what is your workup in this case?
See, if sometimes you have a patient with recurrent UTI and you have an indwelling source like an infected cyst, then you give them prophylactic antibiotics for around 6 weeks. Whereas in a patient with high risk, especially the female gender, diabetes, presence of stents, native kidney disease with urological malformations, retransplantation, these are all associated with higher degree of recurrent UTIs and better to treat these patients. And vesico-urethral reflex appears to be a unique risk factor in this particular population. So if a patient has vesico-urethral reflex, please be careful. And usually nowadays the drug of choice is long-term administration of trimethoprim with self-methoxazole, usually a single strength, that is 160 trimethoprim with 800 milligrams, and we usually give it for 6 months post-transplantation. And this is especially recommended in high-risk patients, especially patients with urinary reflex, patients undergoing second transplantation, or patients with voiding disorders.
But, sir, in this case, the transplant happened 14 months back, and now patient present with 3 culture positive UTIs.
Yeah.
So,
basically, in evaluation, we first do a ultrasound, check for the post-void residue, check
yes,
for
sir.
any prostatitis. If there's any structural abnormality present, please go for corrective surgery, especially reflex or something. But if you find no structural anomaly on the ultrasound, do a voiding cystourethrogram. In the voiding cystourethrogram, if you find no reflex, you perform a urodynamic study. And if there is bladder dysfunction present in the urodynamic study, treat medically, which we have already seen something like neurogenic bladder. And if the patient urodynamic study shows outflow obstruction, surgical management of the prostate and bladder neck is advised. If voiding cystourethropy shows the presence of reflex, surgery should be considered, or nowadays endoscopic injection of deflex injection can be considered.
Even, sir, asymptomatic bacteria?
Asymptomatic bacteria, no risk factors, especially no retransplantation, no diabetes, no male gender, definitely no need for treatment. But if a patient already has prior voiding dysfunction, female gender, diabetes, please consider prophylactic antibiotic.
No, sir. My query is the patient is with reflex in native kidneys and now present with the culture positive bacteria.
Yeah.
So,
If the patient has reflux, we should be aggressive because these patients, especially, they are very prone for pyelonephritis, and this pyelonephritis can affect the transplant kidney as well. So we have to treat the reflex either by surgery or you have to think of deflex injections, endoscopic injections.
okay, so each and every case, the patient with reflux and positive culture, you will go for the surgery or we will put the patient on prophylactic antibiotics.
No. If a patient with reflux is a high candidate, he is the most susceptible candidate for graft dysfunction. So he has to undergo either, we have to be aggressive or you lose the graft. So either you go for surgery or you go for endoscopic injections.
Okay. So what is your management here in this case?
In the case with the reflex, surgery, definitely surgery. Whereas if the patient has a recurrent UTI and he has a catheter for some other reason, early removal of foreign material, and then, as I told, reflex retransplantation, voiding disorder, especially these are the high risk group, you have to give them single strength Septron for 6 months. And nowadays, the promising therapy is vaccination. Although this is not yet come into the market, here the inactivated species of E. coli has been used, Morganella has been used, Proteus, Klebsiella, Enterococcus faecalis. They are still in trial stage. but they have given nearly 80 to 90% success rate, and they are very easy oral or subcutaneous sublingual administration. And coming to general behavior modifications, you should ask the patient to drink in such a way that the urinary excretion per day is at least 2 to 2.5 liters. And the patient should be advised how to use urine dipsticks at home, and so that he can take home treatment on demand. In a female patient, genital hygiene, especially wiping after urination, and postcoital precautions, and maintaining the urine pH with vitamin C and methionine. And in older people, vaginal estrogen has been found to be useful, whereas cranberry juice has been found to be useful in younger patients, whereas in older female patients, the role is still debatable. And patient, if he has a large residual urine, can go for intermittent self-catheterization.
Yes, sir. Nicely explained, sir. And the scenario is that in this case, creatinine rises to 1.8 milligram percentage. So, what you suggest, whether it is UTI or rejection, and what will you do in this case? If
No, see, there are different differences in rejection and infection.
Yes, sir.
In rejection, the creatinine raise is acute, so all of a sudden, and often it happens with small growth of, the fever is not so much. Whereas if you see UTI, the creatinine raise will be acute along with fever. Similarly, if you see rejection, the creatinine rise is far more than what you see in a rejection, in a urinary infection. Presence of fever or high fever especially is more in favor of UTI, because in rejection you don't see high grade fever. Graft tenderness usually in UTI is often present and severe, whereas in rejection the patient has usually mild or dull ache. And when you do a urine analysis, pyuria, hematuria, they are all more in favor of urinary infection. Whereas if you see rejection, they will have proteinuria more than what you see in infection. And when you see blood pressure, usually in a patient with infection, the blood pressure will be normal or on the lower side, especially when the patient is going to sepsis. But when you see rejection, the blood patient usually will have hypertension. And when you see the blood test, you will have leukocytosis, ICRP in infection, and in rejection you see a normal or low WBCs. And of course, in ultrasound, you can see the presence of moderate hydronephrosis or abscess in favor of infection, whereas generally it's normal in rejection.
Yes, sir. Yes, sir. Very nicely explained, sir. And a brief scenario is the patient present with candidiuria persistent. Then will you treat this patients or you ignore this patient?
Usually, candidiuria is very common. Usually, 10 to 12% of the transplant patients or general patients themselves will have candidiuria. Specifically, it's not so well characterized in renal transplant patients. And this is not an infection, it is more in favor of a colonization. So, the infections are usually asymptomatic. Occasionally, they can go to pyelonephritis or disseminated candidemia. Indications for treatment are definitely not clearly established, and we have seen that by treating the candida, you are not either going to increase the graft survival rate or you are not going to affect the mortality. So there's no point treating just asymptomatic candidiuria. And in fact, antifungal use may encourage resistant species. And some of the antifungal agents, they interact with the immunosuppressive therapy. And certain drugs require intravenous administration, complicating the management of graft. So the key takeaway in candidiuria is it's often benign, can occasionally become serious. Treatment deficiencies must balance the risk of resistance and drug interaction with immunosuppression changes. Main thing here is small changes. You change the catheter, this itself cures the candidiuria in 40 to 50% patients. Yes, candidiuria in a setting or scenario of neutropenia, especially when the patient has neutropenia, definitely that is the only scenario where you need to treat the patient. Otherwise, just small measures like changing the catheter itself is enough.
Sure, sir. Sure.
I think Dr.
So,
Shailendra, we are running very late.
okay, yeah, so now I conclude this session, and finally we can say that recurrent UTI in transplant patient, and then we have to go for the search for cause and don't treat asymptomatic bacteria blindly. Balance infection control with resistance. Yes, sir. Thank you. Thank you, Raghavan sir.
Thank you.
Thank you, Dr. Shailendra, Dr. Raghavendra. Dr. Nachiket. Hello.
Yeah, thank you, sir. Sorry, we're actually running out of time. We've shot way over time. We would have loved to continue the discussion. Now we're coming to the last part of the webinar today, and this is by Sanjay Sinha, sir. And he has been so kind. Sorry, sir, to keep you waiting. Actually, Shailendra also had to go somewhere, and I see that you're also traveling. So it's going to be a talk on non-antibiotic strategies for recurrent UTI, which is very important from the perspective that now we have new molecule which has just been introduced. So now I hand over to Sanjay Sinha, sir. Please, sir.
Thank you so much, Nachiket, and I hope you can hear me. Can you hear me?
Yes, sir. Perfectly, absolutely sound and clear.
Yes,
Right. I'm sure you'll get a little bit of disturbance from the traffic. Okay. I have a brief presentation and I deliberately only kept 5 slides for this because I thought I would leave enough time in case there are any questions or discussion that you would want to do. So can you see my slide?
Yes, sir. Yes.
Yes,
Okay.
sir, we can, sir.
Right. So the mandate I have is to speak on non-antibiotic strategies for recurrent UTI. Now, essentially, we know that recurrent UTI implies somebody having recurrent UTI implies that there are at least 2 infections over a 6-month period or 3 over a year. So recurrent UTI is common. So a single infection occurring happens at least 50% of women in their lifetime will get one infection, and about 3% of the population gets recurrent infections. It's fairly common. But people's the implications of an infection varies dramatically between different individuals. So there can be some people in whom the infection is just transient dysuria, a little bit of discomfort for a few hours and it settles down. And in others, it might land them in the ICU with hypotension. So obviously our approach cannot be exactly the same for both of these classes of patients. So this is an important subject. It's a common problem. And equally important is the fact that it's also the commonest misdiagnosis that happens. So a lot of women who walk into the outpatient and say that I've had 10 infections in the last 1 year actually are not suffering from infection at all. So it's one of the most important reasons for misuse of an antibiotic with collateral damage in the community because of antibiotic usage. And hence, this is a very important subject. So what are the important recommendations of the current EAU guidelines of 2026 on the subject of recurrent UTI? Vaginal estrogen in postmenopausal women is a strong recommendation. Methenamine hippurate, which we'll discuss shortly because this is the focus of our presentation today, it's a strong recommendation to use methenamine hippurate to reduce recurrent UTI in women who do not have abnormalities of the urinary tract. We know that antibiotic prophylaxis is effective, and all guidelines show that, but it carries consequence. What are the other important recommendations from the EAU guidelines? Cranberry products have a strong recommendation with a qualification that the quality of evidence is low, and at least in my clinical practice, I seldom use it. Increasing the fluids can help in reducing recurrent infections, but this is based on a single study, and really, we need better guidelines in terms of urine volumes rather than intake of fluids to be able to actually apply this across different patient populations in the world. Drugs like probiotics, D-mannose, plant extracts, bladder installations, for all these, there's a weak recommendation from the EU guidelines. And immunomodulation, such as vaccines, are only recommended as part of clinical trials at this point. So let's now look briefly at methenamine. So methenamine is quickly absorbed after an oral tablet. Most of it is unchanged, excreted unchanged in the urine. And then you have a pH-dependent cleavage of methenamine into formaldehyde and ammonia. The formaldehyde is released below a pH of 6. Below a pH of 5.5, this release is accelerated. And above a pH of 6.5, it comes down sharply. So you need to have an acidic pH for the drug to act. After the drug splits into formaldehyde and hippuric acid, the hippuric acid further lowers the pH, which enables more and more of the drug to keep getting cleaved into formaldehyde, and the formaldehyde inhibits bacteria. Now, it's important that you need an acidic pH, and hence, if you have infection with organisms which alkalinize the pH, such as Proteus or Pseudomonas, the drug might not work. You should not be using concomitant alkalinizers, and that's obviously logical. And you don't want to use sulfonamides because they can precipitate and cause ATN if you use along with sulfonamides. In general, the drug is well tolerated. You get adverse events in about 1 to 10%, and in randomized trials, in about roughly equal to the adverse events are roughly equal in the antibiotic arm and the methenamine arm. And it's contraindicated in advanced renal or hepatic insufficiency or patients who have gout or metabolic acidosis. What's the high quality evidence behind the recent methenamine recommendations? There are two important studies, the ALTER trial from UK by Harding, which examined 200 odd women over a 12-month period in a randomized trial, followed by a 6 months post-treatment period. And what they showed was that methenamine was non-inferior to antibiotics in terms of preventing infections. And the threshold for non-inferiority was placed at 1 infection per person per year. And the drug had less than a difference of 1 infection. The adverse events, as I said, were similar in the two groups, about 24-25% in both the groups. The other important trial was a trial comparing methenamine against a placebo, and this was in a geriatric population from Scandinavian countries. And again, it showed a 25% reduction in the episodes of infection in the antibiotic arm, in the methenamine arm, as compared to the placebo arm. Well tolerated once again. So what would be my approach to prophylaxis? So let's take a 60-year-old woman who's diabetic with recurrent infections. And if a patient comes like this, the first thing that I would examine is this really recurrent infections or is it something else? Because we know that problems like overactive bladder, GSM, bladder pain syndrome, vaginitis, voiding dysfunction, or a mix of these can all present with symptoms which mimic UTI. Once I have come to the conclusion that this is a recurrent infection, then the next thing I would look at is, are there other major undiagnosed factors which might be contributing to recurrent infection, such as, is there an underlying stone? Is there lower tract dysfunction? Is there uncontrolled diabetes? Could these be triggering recurrent infections? And toward that, I would of looking at the HbA1c, the Euroflow, the PVR, the ultrasound as appropriate. So obviously, as a part of making a ruling in an infection, it's important to make sure that the urine exam is abnormal. So a positive urine exam doesn't rule in an infection, but a negative urine examination has a high exclusion value for excluding a diagnosis of infection. Next is to look at the usual triggers for infection. Just because a woman is 60 years old doesn't mean that the usual triggers don't apply. So whether it's post-intercourse, whether there's associated constipation, etc., all these things need to be examined in a woman with recurrent infection. And then the first step would be intravaginal estrogen, as we just discussed. This is a strong recommendation from all the international guidelines that intravaginal estrogen helps. Now, if the patient fails intravaginal estrogen, or if there are serious consequences of infection, let's say the patient lands up in the ICU each time, those kind of patients, I might not just rely on intravaginal estrogen. And here, I would categorize this into 3 different groups of patients. One in whom there's occasional infection, which is minor. Here, I might just tell them to take on-demand single-dose antibiotic by themselves. In patients who have frequent consequential infections, if there's no contraindication to methenamine, then in today's, with the availability of methenamine, I would choose methenamine in preference to an antimicrobial in these patients. But if the patient has, let's say, repeated hypotension, those kind of episodes, or if the patient is failing methenamine, in those patients, I've used regular antimicrobial prophylaxis. Usually, it would be nitrofurantoin, and that would be my typical approach in terms of how to prevent infections. I think I will stop at this point, and if there are any other questions or comments, I would be happy to take them.
Only one question, sir, from my side. I think you're already late, sir. How long can we continue methenamine? I mean, studies have given it for only 1 year, but can we go beyond it, sir?
So really, we don't have good quality data. What we also know is that after stopping methenamine, in both studies, the ALTER trial as well as the Scandinavian study, after stopping the methenamine, the infection rate actually was higher in the methenamine arm compared to the other arm.
So we really don't know whether there's something else going on. These studies were not designed to examine this question. So I think it's safe to say that the drug can be easily used for a year, because there's randomized trial data about that, and very likely you could use it longer. But I wouldn't start off with a prescription of a year. So I wouldn't just change the duration of my antimicrobial prophylaxis, of the prophylaxis I use, just because I have methenamine instead of an antibiotic. So I would use it just like an antibiotic to start with. So initially with a 3 or 6 month antimicrobial prophylaxis, and then take it from that point.
Thank you so much. It was a very interesting point that you brought out, that studies show that after 1 year, actually the incidence of UTIs can increase. So I mean, only time will tell, and maybe personal, data and personal experience with the drug will be able to get more answers to that. But thank you, everyone.
As I said, the studies were not, as I said, the studies were not designed to answer that question. So the ALTER trial, if you look at the confidence intervals for the infection after stopping the drug, the confidence interval actually crosses 0, saying that if you look at the p-value, it would probably be not significant. But if you look at the breadth of the confidence interval, most of it is in these a difference between the two arms. So if you look at the other study, there was a difference. It was higher in the methenamine arm after stopping.
Thank you so much, sir. Always a pleasure listening to you, and please do have a safe journey. And now I'd ask Surya sir maybe if we can call Keshav sir and for concluding remarks.
Thanks.
Surya sir.
Thank you, Sanjay sir. And I think not many questions. There was one question pertaining to the last case discussion: role of native nephrectomy in recurrent UTI. Dr. Raghavendra, you want to take, or we'll conclude?
I think that maybe we can conclude, sir, and we'll put it up inside the chat box on the e-learning platform, because we're way over time. Sorry, and yeah, please.
Okay, then we'll conclude. Thank you very much, all the faculty. It was really a very exciting webinar. I thank Dr. Nachiket for really making a very nice program involving many senior faculty. Though the topic was very exhaustive, we could cover. That's the reason we got beyond the time, because there was many points to discuss and it's not possible to cover all the cases in the given time. But we had a very meaningful discussion. I sincerely thank all the speakers: Dr. Samir Trivedi, Dr. Shivam Priyadarshini, Dr. Pavan, Dr. Mukesh Arya, Dr. N.P. Gupta sir, Dr. Umesh, Lalita ma'am, Dr. Harpreet, Sanjay Sinha sir for his excellent talk and nice case discussion, Dr. Gautam for his very insightful case discussion on stones, Dr. Rahul Gupta, Dr. Shailendra, and Dr. Raghavendra. Thanks to all the audience who have participated in this discussion. The entire program is recorded and we can watch it later on the e-learning platform. Thank you very much. Thanks, Dr. Keshav could not join. And thank you, Dr. Nachiket. We can give some concluding remarks before then we could close.
No, sir, thank you. I thank you for giving me this opportunity. I thank Keshav sir and I thank Uttam Mehta sir. And I also would like to thank all the faculty who have taken out time. And I apologize for my time management. Maybe I'll do a better job next time. And we've shot maybe around 40 minutes over the permitted time. But this is something, there's always some learning inside all of the webinars. Besides, academic content, maybe managerial content. I'll try to be, more, I'll try to be more strict with the time next time. But thank you so much. And thank you all of the faculty once again from the bottom of my heart. Thank you so much.
Thank you. Thank you, everyone. Thank you. Good night. Good night. Bye. Thank you.